Okay, we're going to get started now. My name is Dr. Carrie Clark. I am the Director of Nursing and a Professor of Nursing at Pacific College of Health and Science. I am also Chair of the Medical Cannabis Certificate Program, and I'm the past President of American Cannabis Nurses Association. And we're presenting a fabulous masterclass for you tonight in celebration of International Nurses Day. So this whole last week has been Nurses Week, and today is the 200th anniversary of the birth of Florence Nightingale. And so we partnered with American Cannabis Nurses Association to really bring you this very hot topic about COVID-19, cannabis care, and what it's going to take to recover from a lot of the trauma that has happened to so many of us. And we brought together two great experts for you. One is my colleague, Eloise Theisen. She is a nurse practitioner and she's board certified as an adult geriatric nurse practitioner. She is the chief executive officer of a company called Radicle Health, which provides education for providers that are interested in learning more about cannabis care. And she also sees patients through Radicle Health, and she's cared for thousands of cannabis patients. So she brings a great wealth of experience. And she's current president of American Cannabis Nurses Association. So she's my great colleague, and we also teach together at Pacific College in the Medical Cannabis Certificate Program. If you're interested in any of our programs at Pacific College, you will want to contact us at our website when this webinar is over. And co-presenting with her is Timothy Byars. He's the president and chief education officer of Radicle Health. And he has a great background in curriculum development and over 20 years of experience with things like writing and developing content for curriculum. And he's also currently enrolled in the Masters of Science program in Cannabis Science and Therapeutics at the University of Maryland in Baltimore. So we're super excited at Pacific College to bring you this master's class on this very special day. And I'm going to turn it right over now. Thank you so much for joining us.
Thanks, Carrie.
Yeah, thank you, Carrie. Thank you for the warm welcome and the warm introduction. And I'll let Tim go ahead and get the slide deck up for us and go ahead and get started. So we're very excited to be partnering today with Pacific College of Health and Science. And we really hope you enjoy this presentation. Go ahead and do the next slide, please. We just want to make sure everyone knows here today this presentation is for educational purposes only, and the information presented today is not intended to be a substitute for medical advice. And while we have plenty of experience in cannabis, we are not experts on viruses. So this information is not meant to help in the diagnosis, prognosis, or treatment of COVID-19 or any other virus, disease, illness, or condition. We're proud to say, oh, you can go back. At Radicle Health, we're proud to say that we are partnering with Pacific College Health and Sciences to trial our full suite of modules for the students in the medical cannabis certification program. So for some of you students, you may be recognizing some of this content. Okay, ready for the next one, please. Okay, so COVID-19, welcome to the new normal, right? What you're seeing here is that coronaviruses known as CoV infect a wide variety of animals, causing respiratory, gastrointestinal, hepatic, and neurological diseases. CoVs are classified into 4 genera. We have our alpha coronavirus, our beta coronavirus, our gamma coronavirus, and our delta coronavirus. So the virus is SARS or CoV-2. And the disease is COVID-19, coronavirus 2019. Let's hope we don't have a COVID-20 or 21. Next slide, please. We've identified 7 CoVs in humans. They account for about 5 to 10% of acute respiratory infections. It elicits an excessive immune reaction. It can lead to cytokine storms, which we'll talk a little bit more about. It causes extensive tissue damage and multi-organ dysfunction. Only the alpha and beta coronaviruses to date are responsible for human infections. And there are 4 circulating strains of human CoVs that have likely circulated in humans for centuries. And some of these 4 are some of causes of the common cold. So again, about 10 to 15% of colds are caused by these viruses. 3 additional CoVs recently emerged into the human population through species jumping or zoonotic transfers. They're SARS-CoV, MERS, and SARS-CoV-2. They've definitely identified risk factors for COVID-19, which is older age, male, high blood pressure, comorbidities like obesity, diabetes, heart conditions, and ethnicity. We're seeing African Americans are contracting COVID at higher rates and are more likely to die. There's also some information now coming out about vitamin D levels that are suboptimal may also be a risk factor in terms of how bad the disease may be. Next slide, please. In this slide right here, symptoms can range from mild to severe, and I think the list of possible symptoms is changing quite frequently. I think we've seen 9 different mutations of COVID-19 since it was first identified, but to date we've identified fever, cough, shortness of breath or difficulty breathing. We're now seeing also what we, hypoxia, where some people have very low levels of oxygen, but maybe aren't short of breath or having difficulty breathing. We're seeing chills or repeated shaking with chills, muscle pain, headache, sore throat, loss of taste or smell, fatigue, diarrhea, runny nose or nasal congestion, and more recently, some skin conditions and rashes have been identified. Symptoms can appear within 2 to 14 days after exposure. Next slide, please. We know that about 81% of people who develop symptoms will have mild symptoms, and they may develop mild pneumonia or no pneumonia at all. About 14% will have severe symptoms, an oxygen level that drops below 92%, and respirations over 30 breaths per minute. Lung infiltrates over 50% of the lung, and this can occur within 24 to 48 hours. About 5% will be critical with respiratory failure, septic shock, multi-organ disease, or failure with rapid worsening after a week of symptoms. And the mortality rate, well, I think it's really hard to identify what the exact numbers are of that right now. All right, I'm going to turn it over to Tim to discuss viral
Viral pathogenesis. Thanks, Eloise. So we're not going to go into depth about the virus or the disease. This is not our area of expertise, but we do, however, want to have a foundational understanding of the effects of COVID so that we understand how cannabis fits in. So everyone has seen this illustration before. This is a very typical coronavirus. It's spherical. It has a crown of club-shaped spikes on the surface, and of course these spikes are actually proteins, and each of these proteins, they all serve different purposes. Specifically the ones that we're interested in today are the ones that facilitate the attachment to cell receptors in humans. You can also see in this illustration these coronaviruses have an envelope, and inside of that envelope membrane is a single-stranded RNA. Now, this is a lipid membrane, so that's the reason why it's so important to wash your hands and to clean surfaces, because these lipid membranes are easily destroyed by soap and cleaning agents. There's a lot we still don't know about COVID-19 and coronavirus. There might be multiple ways to become infected, but the most common method is through respiratory droplets. But we should also talk briefly about fecal-oral route. So the fecal-oral route of infection is less understood than the respiratory droplet route. We do, however, know that the receptor to which this virus binds is highly expressed in the small intestine. We also know that patients hospitalized with COVID have tested positive in stool samples. And furthermore, there have been patients who have tested positive in stool after testing negative in respiratory samples. And these are patients who typically present with nausea or vomiting or diarrhea. Now, that said, CDC has stated that it's unclear whether the virus, when it's found in feces, may be capable of causing COVID-19. And to my knowledge, to date, there haven't been any confirmed reports of the virus spreading from feces to a person. So today we're going to focus on, oops, wrong way. So today we're going to focus on the respiratory droplet route. So obviously this virus can be spread by sneezing and coughing and even potentially through direct conversation. And this might help explain why people who are asymptomatic can actually spread COVID-19. So an infected person can spread this disease to another person who's 6 feet away. We know that it might be airborne for as long as 3 hours. There's some research that suggests that when this virus is expelled by a cough or a sneeze, it can travel 25 feet in a second. So the concern here obviously is that someone can subsequently walk through the virus and inoculate themselves. It might stay on surfaces for hours, maybe even days. It depends on the type of surface. So we know, of course, that the virus can infect the lungs, but we're also seeing infections in cells throughout multiple organ systems. So we're seeing infections in the heart and the kidney and in the liver. But today we're going to just focus on the lungs, and to keep things simple, we're going to look at how the pathogenesis produces the 3 main symptoms of COVID-19. So the dry cough, the shortness of breath, and fever. So when you inhale this virus, it makes its way into the lungs to the alveoli. Alveoli are small, they're balloon-shaped sacs that they're at the ends of our respiratory branches. And this is where your gas exchange occurs. So the oxygen that you breathe in gets transferred into the bloodstream, and then the carbon dioxide that's in the bloodstream gets transferred into the alveoli and then gets expelled when you exhale. And we have about 600 million alveoli in our lungs. So you can kind of see what they look like on the left-hand side here. They look like bunches of grapes, and they're surrounded by blood vessels, by very small capillaries. And again, this is what's facilitating the gas exchange. On the right-hand side of this image, you can see a single alveolus. And you can also see that the surface of these alveoli are covered in a thin layer of cells, and these are epithelial cells. And epithelial cells cover the surfaces of our body. They cover our skin, our blood vessels, our urinary tract, our organs. Essentially what epithelial cells do is they protect the inside of us from everything that's external to us. Now, in the alveoli, there are 2 types of epithelial cells, and just for the sake of simplicity, we're just going to call them type 1 and type 2. Type 1 are responsible for gas exchange, and you can see them here in the illustration. They're very thin, they're flat, there's a thin layer. I've heard someone refer to the thickness as being 10 times as thin as a sheet of paper, for example. Type 2 cells, which unfortunately are not, they don't appear in this illustration, but type 2 cells are, they're larger and they're cuboidal shaped. And these are the cells in the alveoli that produce surfactant. So surfactant in the alveoli are ensuring that the alveoli don't collapse upon themselves as they're expanding and contracting with air. The surfactant is ensuring that they're not collapsing. And we'll talk about why this is important in just a couple of minutes. So the virus attaches to a cell receptor on type 2 cells, on the cuboidal shaped type 2 pneumocytes in the alveoli, and these are called ACE2 receptors. Now, once the virus binds to an ACE2 receptor, it's actually brought into the cell via endocytosis, and the virus is released into the cellular space. The RNA in the virus is released into the cellular space. And once that happens, the virus does what viruses do. It hijacks the cell, and it turns the cell essentially into a workshop for creating the proteins and the other materials that are necessary for creating new copies of the virus. So these new copies eventually are released then out of the cell back into the alveoli. Now, the viral infection will damage these type 2 cells. This is eventually going to lead to cell death. So when these type 2 cells are damaged, they send out molecular signals to alert adjacent cells that there is a virus in the vicinity. So immune cells start to migrate to this area, and they begin to release pro-inflammatory cytokines and other material that are intended to mitigate and regulate the immune response. So now you have, at this point, you have millions of copies of virus in your alveoli. You have all of the cellular material that is leached out of the damaged and dead cells into the alveoli. You have molecules that are being brought into the alveoli because of the immune response. And this all causes a cough reflex. All of this stuff causes a cough reflex, and this is the dry cough symptom. This is a really great illustration here, and I put the link at the bottom so that you can follow up. They do a wonderful job of summarizing what the immune response is when COVID attacks the alveoli, but we're going to just kind of approach it from a high level here. So as the immune response strengthens, the blood vessels that are surrounding the alveoli begin to expand and become more porous. This is intended to allow more immune cells into the infected area. However, this also allows fluid to flow out of the blood vessels and into the space between the alveoli and the blood vessel. So now you've got fluid blocking this gas exchange. More white blood cells are entering the area, they're attacking the infection, but they're also causing damage to that thin layer of type 1 epithelial cells in the alveoli. And this can cause fibrosis or scarring. So you have dead type 1 cells now along the alveoli walls. So now you have fluid blocking the gas exchange, you have fibrosis happening along the alveoli walls, you've got mucus that's in there because of the immune response. And at some point, because of all the damage that's happening to the type 2 cells, remember, these are the cells that are producing surfactant. What happens is that these alveoli will begin to collapse upon themselves. All of these events contribute to a shortness of breath. So now you have the inflammatory responses worsening, the blood vessels are getting more porous, the inflammation can start to spread throughout the body. So now you have excessive and uncontrolled levels of cytokines that are being released. These are activating more immune cells. And again, these have this inflammation now spreading throughout the body. And this is hyperinflammation or systemic inflammation. And sometimes this is referred to as the cytokine storm. And Eloise will talk more about this in just a minute, but this type of response can lead to septic shock, and it can also lead to multi-organ failure. So lastly, you have cytokines now that are traveling through the bloodstream, and eventually they reach the hypothalamus in the brain, and the hypothalamus controls body temperature. So in response to the infection, the hypothalamus is continually raising your temperature until you have a fever. And so that's the third typical symptom in COVID-19. And I'm going to turn it back over to Eloise at this point, and she's going to talk a little bit more about cytokine storms.
Thank you, Timothy. So go ahead with the next slide, please, when you can. Thank you so much. So cytokines are secreted by immune cells, and they are proteins that regulate our inflammatory responses to disease and infection. There are pro-inflammatory and anti-inflammatory cytokines. The excess secretion of pro-inflammatory cytokines can trigger a cytokine storm. For example, when too much of the cytokine tumor necrosis factor alpha is produced, the results can be an autoimmune disease such as rheumatoid arthritis. Cytokines will raise immune activity, and then the body starts attacking the healthy tissues. It can result, like Tim said, in fluid leaking into the lungs, a drop in blood pressure, and blood clots that can lead to a decrease in blood flow to vital organs. That poor blood flow to organs can cause one to go into shock, risking permanent organ damage or death. And as Tim mentioned, fevers are common, excuse me, and about half will experience neurological symptoms as well, which have been classified as headaches, seizures, or possible coma. It's estimated that about 20 to 30% of patients with COVID-19 in the United States are experiencing a cytokine storm. And cytokine storms are not new to some of the other pandemics we've seen. In fact, it's been linked to the 1918 pandemic and the 2003 SARS virus. And more recent data showed that about 4/5 of H1N1 patients met the criteria for a cytokine storm. And treatment has consisted of steroids to decrease inflammation and quiet the immune system. However, steroid use in COVID-19 has not been determined to be helpful or harmful at this point. Take the next slide, please. So currently there are no treatments that have been identified as curative. We really, the recommendations are to focus on supportive care and prevention of transmission. Oxygen therapy is a major treatment intervention, and they are recommending to avoid mechanical ventilation whenever possible. Antivirals and antibiotics are not recommended. A new procedure called ECMO has been demonstrated to be successful in critical cases, and they've been looking at a new drug, Actimar, has been used for cytokine storm and is an IL-6 antagonist. Next slide, please. Initially, though, with COVID-19, there was some promise around hydroxychloroquine produced, but a large study showed that it produced no benefit in COVID patients, and there's a high toxicity with this drug. So the side effects have definitely outweighed any benefits. So cannabis and COVID-19, then, we know there exists an interaction between cytokines, immune cells, and the endogenous cannabinoid system when combating inflammation. And we know that stimulation of our CB2 receptors can suppress inflammation. Cannabinoid receptor signaling confers therapeutic effects by downregulating inflammatory cytokine expression. And although CBD has little direct binding affinity for the CB2 receptor, CBD also acts as a potent anti-inflammatory, reducing cytokine production and inhibiting immune cell function. Next slide, please. Thank you. Wait for it. So cannabinoids can be immunosuppressant, and patients with autoimmune diseases and chronic inflammation can often benefit from using cannabis. THC and CBD are both potent anti-inflammatories and can reduce cytokine production and inhibit immune cell function. Can cannabis calm a cytokine storm? The answer is we don't know. Next slide, please. We know that cannabinoids, as we said, can have an immunomodulating effect. The ability of cannabinoids to both inhibit and potentiate immune function suggests that the endocannabinoid system immunomodulation is bidirectional. It inhibits inflammation under healthy conditions and potentiates inflammation when needed to fight infection. Research and mounting anecdotal evidence suggests that cannabinoids have an adaptive immunomodulating effect rather than simply an inhibiting effect. The ability of cannabinoids, excuse me, cannabis then is likely helping the endocannabinoid system maintain equilibrium to organisms. Next slide. I think this is where I'm going to let you come in, Tim, and talk about the existing research with cannabis and COVID.
Thanks, Louise. We always want to return to this question, can cannabis help with COVID-19? And there are certainly companies on the internet that will claim that their CBD product can help treat or prevent or even cure COVID-19. It's important to note that there's no evidence of efficacy right now. But there is some existing research that we can look at to evaluate the therapeutic promise of cannabis in COVID-19 and other similar conditions that are characterized by hyperimmune responses. So, for example, there's some limited evidence that CBD might help address viral infections. And there's one in vitro study that suggested that CBD had a direct antiviral effect against hepatitis C virus. And this is actually, hepatitis C is actually in the family of coronaviruses. In another study, CBD reduced neural inflammation in a virus-induced animal model of multiple sclerosis. Now, in this study, researchers speculated that the effect might actually be due to CBD's efficacy as an anti-inflammatory, not necessarily specifically for its direct antiviral activity. There is some anecdotal evidence suggesting that CBD can help treat viral infections, things like shingles and herpes. So this is plausible, but it hasn't been borne out yet in clinical studies. This is a company called Calaterra, and they're in phase 2 clinical trials to assess whether CBD is effective for treating graft versus host disease. So this is caused by a systemic immune rejection of an organ transplant or a bone marrow transplant. GVHD and COVID-19 fatalities both include a hyperimmune response. The critical difference, however, is that CBD to date has never been tested as a remedy for a viral-induced cytokine storm. So there are several studies that are occurring now to study whether cannabis can be a novel treatment specifically for COVID-19. And this is one of them. This is Sterobiotech. This is a company out of Israel. They started a small 10-patient trial with CBD and COVID-19 hospitalized patients. They're studying whether CBD can enhance the effectiveness of steroids. So they started with 10 patients. Depending on how the initial treatment goes, they may expand it to to 40 COVID patients. This is a really interesting study. This is a company, again, these guys are out of Israel as well. They're testing whether CBD-loaded exosomes might mitigate inflammation in lung cells. So they have a product that they're testing. They're testing it against a variety of lung functions, not just against COVID-19. Exosomes they're small particles that are created when stem cells multiply. And they actually act as homing missiles, and they can target specifically damaged organs. And they have an important role to play in cell-to-cell communication. This is a third study. This isn't sponsored by any corporation. It's actually just a couple of doctors that are in a hospital in Tel Aviv. And they're examining whether cannabis, because of its anti-inflammatory properties, can slow down lung infections experienced by many COVID-19 patients. So researchers here are testing whether CBD can help stop the cytokine storm in COVID-19 patients. So really looking specifically at that one effect. So there is a lot of work happening right now to test whether cannabinoids can be novel therapeutic agents for COVID and for other respiratory conditions. All right, before I hand it back over to Eloise to talk about post-COVID PTSD, I want to touch briefly on how cannabis has been covered by the press during the pandemic. So we have a long history of cannabis and cannabis users who being unfairly represented in the media. And unfortunately, we see this trend continuing in the context of COVID-19. These are just two examples that I pulled off the internet recently. One is from the UK Daily Mail and one is from Business Insider. Now, I grant you that neither of these is the Wall Street Journal, but it's a reflection of how cannabis is represented in the media. So on the left-hand side, this was a stack of images that was published together. On the top, you have a very young-looking person smoking a cannabis cigarette. Directly underneath is a senior being carted away by first responders, presumably for COVID. I assure you that the proximity and the relationship of these images is not a mistake. They're intended to convey cause and effect. On the right-hand side, I can only assume that this is some supervillain in his lair, dressed all in black and smoking a cannabis joint with his black leather gloves on for some reason. So this is a continuation of, cannabis scaremongering, where the media is consistently representing cannabis as a dangerous substance that leads to issues with addictions and mental problems, inevitable abuse of other drugs, associations with drug lords and violence, and apparently now cannabis use inevitably leads to COVID-19. So I want to show a couple of examples, but this is the type of article that I've been seeing quite a bit in the press. Smoking weed and coronavirus, even occasional use, raises the risk of COVID-19 complications. Most people are not going to read past the headline for this, but if you do, you'll see that there are some pretty typical issues that are raised in these types of articles, and those issues are listed here. The first one is that cannabis smoke causes inflammation. The second is that cannabis users might have confounding variables that confuse diagnosis. So for example, if you were a chronic cannabis smoker, you might already have a dry cough, and that might get confused with a COVID symptom. Patients with COPD and lung disease and asthma are at high risk from severe COVID symptoms. And then lastly, cannabis causes impairment, and you won't be cognizant enough to provide informed consent at the hospital. So we want to come back and address most of these shortly. I'm not going to talk about number 4 because it's an example of obvious hyperbole. But I want to show just a couple more examples first. So this is from the New York Times. Smokers and vapors may be at greater risk for COVID-19. Tobacco and marijuana products damage lungs. So 3 things. I added this for 3 reasons. The first one is that in nearly every vaping story that I read, the story conflates cannabis and tobacco smoking. And we know that the effects of cannabis smoking and tobacco smoking are very, very different. The second reason why I added this is that there was a quote from the US Surgeon General who was speculating that the prevalence of COVID-19 among young people in the United States might be due to their predilection for vaping. Now, it's important to note that there's absolutely no evidence whatsoever of this. In fact, the FDA had to backtrack on its previous hardline position on vaping and coronavirus. They put out a statement in mid-April stating that there is no known evidence that vaping puts an individual at higher risk of developing complications tied to COVID-19. And then the third reason I put it up, there's another quote in this article. It's not listed on the screen here, but it's from Dr. Jonathan Winikoff, and he's the director of pediatric research at the Tobacco Research and Treatment Center at Massachusetts General Hospital. And he said this, quote, "Quitting during this pandemic could not only save your life, but by preventing the need for your treatment in a hospital, you might also save someone else's life," end quote. So I thought this was a really good example of not only conflating tobacco and cannabis use, but also in the context of cannabis, another good example of hyperbole. And then finally, this is from Huffington Post, the scary relationship between vaping and coronavirus. They flatly said that vaporizing vape clouds can actually spread the virus. So we'll come back to this. So we want to look at the literature, but before we do that, I want to be clear that chronic cannabis smoking can lead to bronchial irritation, and in some cases can lead to bronchitis. This is very clear in the medical literature. So we want to state that at the output. So that first issue that we see listed in some of these articles, that cannabis smoke causes inflammation, it's partly true. We know that any combustible smoke can be an irritant. Now, that said, there's no evidence that moderate cannabis smoking causes COPD or asthma. In fact, in multiple large studies have demonstrated that moderate cannabis use can actually increase lung function. And we think this might be due to the fact that cannabis can be a bronchodilator. It can also have anti-inflammatory effects. So going back to those issues, stating that patients with COPD and lung disease and asthma are at a higher risk from severe COVID symptoms, that's absolutely correct, but it's not necessarily relevant to cannabis users. So I think that this excessive hand-wringing about the risk of moderate cannabis smoking and vaping tends to be overstated in the media. With respect to this idea, actually, before I go there, we know that pneumonia is a concern in COVID-19. There's no evidence that cannabis causes pneumonia. This is a study that was done comparing cannabis smokers to non-smokers for 1 year. They found no difference between the two groups. With respect to vape clouds, this is a quote by, this is Neil Benowitz from the University of California, San Francisco, and I won't read it, but essentially what he's saying is, these e-cigarette vapor consists of very small particles of water and propylene glycol and some flavor chemicals. They're not droplets of saliva. These aerosols tend to evaporate very quickly. And really there is no increased risk of spreading COVID-19 through a vapor cloud unless the person is coughing or sneezing when they exhale the vapor. I'm not recommending that you walk through somebody else's vapor cloud, but there's not any additional risk of contracting COVID from a vape cloud. So I'm certainly not an apologist for the vaping industry, especially tobacco vaping. And I don't mean to suggest that you should start inhaling combustible smoke or even vapor during a pandemic. I just think it's important that we read past the headlines in these types of articles to get a better sense of what our personal risk is when we're using smoking and vaping products. And most importantly, if you're concerned about this, we have multiple routes of administration that we can be using when we're using cannabis. You can be using a discretely dosed edible. In legal markets, we see edibles with 1, 2, 3 milligrams of THC, for example, or other cannabinoids. You can be using sublinguals, transdermals, topicals, lots of different options that we can be using to completely eliminate the risk of vapor or combustible smoke. So just lastly, a few general recommendations that we want to make. Obviously, you should avoid sharing anything that you're smoking or using right now. You shouldn't be close enough to somebody to be able to pass them anything unless each of you have 3 feet arms. Always keep your personal collection clean. So if you're using a pipe, for example, use isopropyl alcohol to clean germs and pathogens from the paraphernalia. You can limit or avoid exposure to combustive smoke altogether. You could use vaporizers, flower vaporizers, or you can use, again, edibles or tinctures or some other route of administration if you want to eliminate that risk entirely. Please, please, please only buy legal cannabis from legal dispensaries. Molds, pesticides, bacteria, other toxins, they all can compromise the immune systems. And we often see these kinds of toxins in products that are sold through the illicit market. Don't use any vape cartridges with ingredients other than cannabis and terpenes. So if you see ingredients like PEG or propylene glycol or MCT oil, coconut oil, vegetable oil, none of these ingredients should be heated up and inhaled into the lungs. And then finally, don't believe any claims from companies that are claiming that their product can cure COVID-19 or treat COVID-19. There's a lot of therapeutic promise of cannabis when dealing with these kinds of immune responses, but we're working through the research now, and we just don't have that kind of information quite yet. So I'm going to turn it back over to Eloise to finish off the talk.
Thank you so much, Timothy. And I think it's really important to recognize right now that while there are no treatments for COVID and there's no cures for COVID, and these claims around cannabis or CBD, helping to treat or cure COVID, there's definitely quite a bit of research to help demonstrate that cannabinoids can be effective in treating things like chronic pain, anxiety, depression, and post-traumatic stress. Next slide, please. And, we're recognizing now with this pandemic that many people are experiencing trauma for the first time, and some people are having trauma that is resurfacing for them during this time. And PTSD was first proposed as a diagnosis in 1980. And currently the lifetime prevalence rates are 3.6% and 9.7% among US men and women, respectively. They did look at post-traumatic stress rates in places with post-conflict settings, and those rates were as high as 37%. And in 2013, when the DSM-5 came out, they did make it a requirement that in order to have a diagnosis of post-traumatic stress, you had to be exposed to a traumatic event that involved death or threatened death, actual or threatened serious injury or threatened sexual violence. Next slide, please. So what does the research say about cannabis and post-traumatic stress? In 2018, researchers in Texas performed a systematic review to evaluate the evidence of cannabis use for post-traumatic stress. They looked at 5 studies and found conflicting data for the use of post-traumatic stress. That tends to happen. What they did find that there was a higher rate of cannabis use in adults diagnosed with post-traumatic stress. It was 65% versus 41% for the non-post-traumatic stress diagnoses. We've also looked at synthetic THC. It's been shown to be helpful with the treatment of resistant nightmares and post-traumatic stress, and about 70% had improvement in one study. Next slide, please. We also know that the endocannabinoid system may play a role in post-traumatic stress, and patients with post-traumatic stress disorder have demonstrated an increase in availability and a decreased agonism of their CB1 receptors. So when we're stimulation of the CB1 receptors might decrease anxiety, it can increase serotonin levels, thereby increasing mood and memory and decreasing hypervigilance, hyperarousal, and intrusive memories. These are all associated with post-traumatic stress. Stimulation of our prefrontal cortex may decrease suicidal thoughts and behavior, and stimulation of our amygdala may decrease adverse memories, fear, and anxiety. And a high percentage of patients cannot tolerate the conventional treatment used for post-traumatic stress. Because the endocannabinoid system plays a role in post-traumatic stress, researchers stated that they believe cannabis might be a novel therapeutic option for treatment. Next slide, please. And symptoms from post-traumatic stress can actually lead to depression, anxiety, substance abuse, and suicidal thoughts and behaviors. They can vary in an intensity. They can show up a month after being exposed to a traumatic event, or it can happen years. Stress obviously will make your symptoms worse, and untreated post-traumatic stress is where we have these increased incidences of suicidal thoughts and behaviors. There's different types of symptoms when you're being diagnosed with post-traumatic stress. We have our intrusive, which is recurrent and unwanted distressing memory, flashbacks, nightmares or upsetting dreams, severe emotional stress or physical reactions when reminded of the event. We also have avoidance, tries not to think or talk about the event, avoids people, places, or things that remind them of the event. Next slide, please. We can also see negative changes in mood or thinking. So negative thoughts about self or others, lack of interest in activities, hopelessness around the future, difficulty expressing positive emotions, difficulty with memory, feeling emotionally numb, feeling detached, problems with maintaining relationships. We may also see changes in physical and emotional reactions, easily startled, angry, irritability, aggressive behavior, always on guard, overwhelming guilt and shame, self-destructive behavior, difficulty sleeping, and difficulty concentrating. Next slide. And the standard of care for post-traumatic stress at this point includes antidepressants and psychotherapy. And pharmacotherapy is actually less effective for combat-related trauma. There's also additional treatments, EMDR, which is known as eye movement desensitization and reprocessing. That's been shown to be helpful, as has SIT, which is stress inoculation training. We also see a lot of off-label use of antipsychotics, beta blockers, and benzodiazepines. And what we know about cannabis is it can be much safer, less side effects, so it's better tolerated. And it's something that we want everyone to have safe access to. Next slide. But because cannabis is a Schedule I drug in the United States, our research is definitely restricted and limited. We do have a couple of studies that are ongoing right now looking at post-traumatic stress and cannabis. So a current study was completed with Dr. Sue Sicily, and she looked at 76 veterans who did a triple blinded study using 1.8 grams of cannabis daily with varying potency. So no one knew what they were getting or what their potency was. We're still waiting to get the results of that study. An additional study is being done through the San Diego Department of Veterans Affairs. And they're looking at CBD. It's not plant derived, so it is synthetic CBD. And they did that because they wanted to try to control and standardize the dosages. It's a double-blind study of 136 vets, and they are currently administering 600 milligrams of CBD twice a day. Of course, the challenge with this study is those dosages of CBD are incredibly high. So any vet who does have success with that after the study probably will not be able to afford those dosages moving forward if they are having success in treating their post-traumatic stress symptoms. Next slide, please. And that leads to our challenges that we have right now. We have no standardized dosages, which is sometimes, I think, a blessing. Because we can really personalize cannabis for those who need it. But it can be difficult to obtain, both because of legal status and price. We currently have 33 states that allow for medical cannabis. 2 of those states do not have PTSD as a qualifying condition. We have 11 states that allow for adult use. So those anybody in those states can use cannabis for any reason. So we still have 17 states that have not recognized cannabis as a medicine, and those people with post-traumatic stress in those states actually have no safe access to cannabis as a medicine. So again, it depends on where you live, whether or not you have access to it. It continues to remain federally illegal, which limits our ability to research it. And we have no established cannabinoid protocols, which means many clinicians may not be comfortable with recommending cannabis because they don't understand what to recommend, how much to recommend, what kind of side effects people might see. I'll say that the American Cannabis Nurses Association today, in honor of International Nurses Day, did release a statement on post-traumatic stress and cannabis use. And we are calling for the descheduling of cannabis to increase research so that we can allow for more patients to access this safely and therapeutically. And that leads us to questions. And I think we're going to be fed some questions. So if you just could bear with us while we get those over to us, and we'll do our best to answer them for you.
All right, I am. Thank you so much. We've been having some great dialogue and some questions over here. So I will start. Let's see. One of the questions is asking about people's immune system when it has been suppressed with things like, say chemotherapy. Would that help stop some of the inflammatory response, like a cytokine storm, or do we even know that?
That's a great question. I think, you have other vulnerabilities in that place if you're immunosuppressed from chemotherapy. And does it decrease your chances of having a cytokine storm? That I don't know that I'm qualified to answer that. I would say my concern about being immunosuppressed right now around COVID is how easy it could be for someone to contract that virus.
Right. And that's a great point about the comorbidities too, right? Because usually someone doesn't just have, a cancer diagnosis. They have some of those other risk factors that you mentioned, like hypertension or
obesity, maybe diabetes. Yeah.
Yes. Here's another question for you. Here in the US, my understanding is that CBD is sold as hemp and not, person said marijuana or cannabis. What would the difference be in efficacy or treatment for viruses if the CBD was sourced from either of those sources?
Tim, do you want to take part of that question, or do you want me to take it?
Well, I can start. Really, whether you're getting CBD from hemp or from cannabis flower depends on whether you have legal access. We can buy CBD products here in California that are flower derived. There are some companies who are actually producing really good CBD products from hemp flower. They're being grown not like traditional hemp plants. They're being farmed and grown just like a traditional cannabis flower would be. And in those products, the efficacy should be the same. The CBD molecule is the same, whether you're getting it from a hemp plant or from a cannabis plant. I mean, they're the same family of plants. You just want to make sure that you're getting anything that's hemp derived, you're getting from a quality source, because these types of products don't typically fall under the regulatory structures that cannabis does.
Yeah, I mean, I think, and like you said, Tim, it depends on where you live. And in terms of its efficacy for viruses, I don't think we've demonstrated how effective cannabinoids are in the treatment of viruses. We have some very old data back from 1991 looking at THC as an anti-inflammatory, comparing that to aspirin and hydrocortisone. And at that time, it was 20 times more powerful than aspirin as an anti-inflammatory and 2 times as powerful as hydrocortisone. And we haven't updated that study. So, with the changes in potency of THC from 1991 to 2020, I think it would be really interesting to repeat it. And, as far as I know, I haven't been able to identify any information looking at CBD and its anti-inflammatory effects, how powerful it is. Compared to other anti-inflammatories. But, as Tim mentioned, it's really important that you know where you're getting your products from, that they're being lab tested. And with hemp being an unregulated industry right now, not only can you get a product that has little to no CBD in it, we're now starting to identify how lab testing needs to really become regulated as well in the industry, because different lab companies can set their limits on how much THC or pesticides or heavy metals they're identifying in the product. So there's a lot of really great players out there, and there's also a lot of bad players. So it's really important to do your research if you're going to buy hemp-derived CBD. CBD that comes from a dispensary, a licensed dispensary, usually has to be tested for all of those things. So.
And I'll just add, I think it's interesting when we talk about efficacy of CBD as an anti-inflammatory, there's a lot of, there's still some gaps in our knowledge about how CBD, why it's effective as an anti-inflammatory. It doesn't really bind all that well to either cannabinoid receptor. We do know that adenosine agonists, for example, are anti-inflammatory, and both CBD and THC inhibit the uptake of adenosine signaling. So we think that maybe that's one mechanism in the ECS by which CBD is an anti-inflammatory, but there's still a lot of, there remain a lot of questions about why it has its effects that it has.
Great point, Tim. Thank you.
Thank you so much for answering those. We have a few more. Somebody's wondering what the route of administration for cannabis in the clinical trials in Israel. I'm assuming it's an oral route, but did you have any more specifics on that?
So the Inocan one is actually, I think it's a spray, but I'd have to go back and check. And then the others, I'm certain that it's probably some sort of oral, either it's a tincture. There almost no studies are done. The one that Eloise presented with smokable cannabis, they're nearly unheard of. So most of these are done with oral solutions.
Yeah. Next question. Somebody is wondering about what happened to all those eValley patients, which are the ones that were the vaping lung injury patients. They said they haven't seen it in months. It's barely in the news, and it was like the hot thing at the end of summer and in the fall. So could it, and I guess the question then too is that could maybe that have actually been a viral issue and not actual damage from vaping?
No, but Tim, please go for it.
No, it was damage from vaping. It's coincidentally some of the effects of eValley were very similar to COVID-19 effects. But what we saw was that as we researched the issues and talked to people who were suffering from e-cigarette associated lung injury, they were using products from the illicit market, and these were vaping products that had things like vitamin E acetate, polyethylene glycol, propylene glycol, vegetable oil. These are things that when you heat them up and inhale them, they can turn into lipoid pneumonia. So they're hopefully, I think the message got out at the end of 2019 that you should not be buying products from the illicit market. You should be buying all of your cannabis products through legal dispensaries. So here in California, I'm pretty sure, I haven't looked in the past few weeks, but I'm pretty sure there hasn't been one single instance of an eValley report from a product purchased from a legal dispensary.
Yeah, and I think if I would add to that just really quickly, Tim, what they saw with the eValley was chemical burns were happening in the lungs, which is much different than what we're seeing with COVID in the lungs.
Thank you so much for clarifying that, because I think that's a really important point, because I have seen that floated out there as well. So I'm glad we have some clarity around that, and hopefully people are able to access safer medicine. One more question here. For the states that where people can access cannabis and it's recommended for PTSD, this person's asking if there are current recommended doses for this. So are there any current recommended doses for cannabis and PTSD?
Not based off of any clinical trials in humans that I'm aware of. So I would say no. Tim, do you know of any?
No, I mean, when you look at the systematic search of all of 5 studies with PTSD, when we talk about the research that's available for cannabis and cannabinoids, it's a very large body, but for some disease and condition, it can be very small. And I think this is a good example.
Mm-hmm. There were, when they looked at synthetic THC, there were some dosages used there around 5 milligrams was the dosage that they used there, but that's not considered a standardized dose.
And I think that's where it becomes important too that people that have a really, obviously serious diagnosis like PTSD, they need to be working with a cannabis care practitioner, right?
Mm-hmm.
So that they have that guidance and support as they titrate the medicine. So working with someone like you who's qualified to support them through that. Let's see, someone asked, can you recommend a quality CBD product? And I don't think we'll be doing that tonight. And so maybe you want to talk about, if you have, I think we have still a few more minutes, there's a few more questions, but how do people find a quality CBD product?
Yeah, I think that's a great way to approach it, Carrie. Looking, we wrote a blog about it, some things that you should really be looking at when you're trying to pick out a product, because there's over like 4,000 different CBD products on the market right now. And I think it's just growing every day because of the emergence of CBD. So you really want to make sure that you're getting a third-party lab tested product. Those lab tests should actually have a QR code associated with it that you can scan that takes you directly back to the lab that tested it. So you know that those certificate of analysis have not been doctored or forged at all. You also want to make sure that if you're going to be using CBD for any sort of therapeutic effects, that they're deriving their CBD from hemp flower, and it should say that on the label. We also recommend that the lab results tell you the potency that they're testing for molds, pesticides, fungus, bacteria, heavy metals. We also recommend that you avoid any kind of company that requires you to sign up for monthly subscriptions or multi-level marketing that requires you to purchase large amounts of it and then try to sell it. We also recommend that you avoid toxic additives like high fructose corn syrup and some other things. That way you're getting just a very clean, closest to the plant type of product. Did I miss anything, Tim?
No, I think that was good.
Okay. It's a lot. It's a lot when you're trying to vet a product.
Yes.
Can be very overwhelming.
Right. And that's also where, cannabis coach or cannabis nurse could help you to learn how to read those kind of labels and so forth to help you choose the products. Not that they would necessarily recommend what products, but they would help you to make that choice. So
yeah, how to read a label.
Boy, it seems like now suddenly we have a lot of questions. So we probably won't get to them all. One person was asking about, that was really interesting. Oh, so does it matter if CBD is water soluble? A lot of companies are boasting about nanotechnology and water soluble bioavailability.
Tim, I love the way you answer this.
I think does it matter is maybe the wrong way to ask the question. So, if a drug is more water soluble, it means it's more bioavailable. So it gets into your body a little bit faster, and you can use less of it for the same kind of effect. There are companies who are using nanotechnologies to create water soluble cannabinoids. Mostly these are in beverages, so I think that the options tend to be a little bit. There are fewer of them than if you're using something that's not necessarily water soluble. The acidic cannabinoids are more water soluble generally than their activated counterparts, THC and CBD. But they can be good options for people. Again, because you can use lower doses of these products to get the same effect, because they do have higher bioavailability and a faster onset. So you can consume a cannabinoid orally and actually have a time of onset that's equivalent to when you're actually vaporizing or smoking. So it's an interesting drug formulation approach.
I will say, I believe that some recent information came out around looking at nano infused cannabinoids, and they found that there's a large variability among the different consumers with onset. So I think, again, cannabinoids are so unique, and we still have a lot to learn about them, but Theoretically, I think nanotechnology sounds great. Have we, really perfected it with cannabinoid products yet? I would say no, and that there's still large variability. So just don't repeat your dose after 15 minutes if you don't feel it. Would be the word of caution.
Great. So our hour is up. There's still a few questions floating out there. So I think what we decided we will do is follow up with an email to everyone that signed up with addressing some of those questions. A few people were asking about finding the link to your blog that you had mentioned earlier, Eloise.
Okay.
And so we can also follow up and send that link.
Great.
So thank you so much. I think we had some great participation. The sharing of your knowledge is invaluable. It's been an amazing way to spend the evening celebrating cannabis nursing, Pacific College, Florence Nightingale's 200th anniversary of her birthday, and this International Day of the Nurse. And we hope to see all of you that participated come back, come to more master classes. Join us at Pacific College if you're interested in the medical cannabis certificate program or in our nursing programs or in our acupuncture programs or massage therapy, any of the programs that we have here. And have a terrific evening.
Thank you.